delighted to welcome, now we have Jonathan O'Reilly, Senior Improvement Advisor, NHS Healthcare Improvement Scotland, and the fabulous Joe Matthews, Head of Safety and Improvement Support for NHS Healthcare Improvement Scotland as well. It's fantastic. Joe, I've got you. I can't see Jonathan at the moment, but oh, here he is. We've got something going on. I guess he's sharing the screen. Is that right?
He is. Jonathan's going to share the slides. Oh,
lovely. Okay. Well, look, we're absolutely thrilled to have you come along and talk on this critically important topic. If you, without wishing to be at all unkind, if you'd rather listen to Professor Richard Williams, who's Emeritus Professor of Mental Health Strategy at the Welsh Institute for Health and Social Care, as well as Royal College of Surgeons of Edinburgh, he's going to be talking about experiences that stress NHS and social care staff. And he's particularly looking at the pandemic. If you'd like to listen to Professor Richard, do please go into breakout room 2, where you'll be looked after royally there. But for now, Joe, I'm going to hand straight on to you, I think. We'll give you an extra 10 minutes here to make up for the time that we've lost. So 14:45, please, for close. If you do have some time for questions as well, that would be fantastic. Thank you very much.
Thank you very much, and I'm delighted to be able to speak with you today about the essentials of safe care and consider within your own services how they can support not only your improvement work around safety, but be a foundation for the delivery of high quality safe care for those receiving and delivering care. As I said, my name is Joe Matthews. I'm Head of Improvement Support and Safety, which includes Head of the Scottish Patient Safety Programme, and delighted to introduce a colleague, Jonathan O'Reilly, who's a Senior Improvement Advisor within the mental health element of the programme. If you move to the next slide, please. Thank you. Prior to COVID, you'll know only too well, services were already experiencing unprecedented demand, and there's no doubt that the pandemic has added further challenges for the system and brought a renewed focus on a range of existing safety problems and uncovered new ones. It's highlighted the challenge of sustaining quality of care right down to the absolute essentials during what was a very turbulent time. And alongside the need to support staff health and well-being, continue to embed real-time improvements and innovation. Safety, however, has been and remained the guiding principle in all the work. And whilst great strides over many years has been achieved through the Scottish Patient Safety Programme and many other improvements in Scotland, I'm sure each of us here today would agree that the work of safety is not done. There's a clear need to build on past gains, nurture impactful current work, and develop new ways to make health and care as safe as it possibly can be. Delivering it in a way that is of value and meaning, not only necessary to improve the safety, but important for those that are at the heart of the changes. People like yourselves on the call today and your teams coming together to be part of something that isn't COVID, that isn't the day-to-day, and is something that can affect long-lasting positive change and can bring purpose and joy in the midst of what we can hear is at times utterly overwhelming. Next slide, please. So for those joining us today for the first time, SPSP is a national quality improvement programme that aims to improve the safety and reliability of care and reduce harm. It's been in existence for over 13 years now, and it has until recently supported improvements in safety across acute and primary care, inpatient mental health, maternity, neonatal and paediatric services, and also medicines, with this focus moving now from beyond health into social care. And at its heart, it's about supporting people to apply quality improvement methods to key safety issues, capturing progress and learning through iterative cycles of testing, and then sharing that knowledge in order that others can improve. Next slide, please. And through this approach, SPSP has been supporting teams, organisations, systems to create the conditions in which safe care can be delivered. So as we all know now, planning for the new context that we're working in, we need to create those conditions to maintain safety for those receiving and delivering care. And that's both a strategic and an operational priority. In developing the next phase of the safety programme, and in particular the essentials of safe care, which I'm going to go on to describe, we've brought about a systematic wide approach to creating the conditions to enable the safe delivery of care for every person within every setting, every time. And through that approach, we've been creating the conditions for the improvement work, not just at a team and a service level, but at that wider board leadership and system level too. Conditions in which people can build an understanding of what needs to be improved and why, have the skills to be able to improve, the permissions to get on and do so, and through that build the will, the trust, the commitment, and that shared purpose of which the work is aligned to. Next slide, please. So as we entered the first lockdown, the whole SPSP programme was placed into hibernation, and many of the team were redeployed into other aspects of supporting the system. During the summer of 2020, the national team embarked on a significant stakeholder engagement piece to understand from services and systems across health and social care what had helped during the first wave of the pandemic, what would help beyond COVID, and how best could a national safety programme support them in doing so. As part of that development of the next phase, we worked with teams across health, social care, the third and independent sector and housing to understand what those priorities were and how best we could actually work with them. Consistently, three themes came through those conversations. The essentials of safe care, understanding what these core elements of safe care were and thinking about how we can ensure that they were in place reliably. A refocus of the specific safety programme improvement areas and a learning system, something that's not new to SPSP, but really enhancing the existing networks and the different resources that enable and facilitate shared knowledge, experience and learning to facilitate that change and improvement. In essence, really creating the conditions for the work to happen. And we launched this phase of the programme last year. Next slide, please. So what are the essentials? They are a package of evidence-based guidance for the safe delivery of care in all settings. And this work brings together existing guidance and standards into one overall package. It includes a driver diagram, a change package and a measurement framework, and an underpinning learning system to support it, all of which that can be applied in health or care. 4 design groups were formed with representation from across health and social care, and they were made up of people who had given us the initial feedback. All the design groups developed the package underpinned by some key principles, designed by and for the system, had a human rights-based approach at the centre of it, built on existing standards and guidance. So there was a real key message about, please, nothing new. Let's get it all together so that it's much easier for people to understand. And also something fundamental to the national improvement work undertaken in Scotland, no mandation. This is about working with and not telling people to do. The group focused on identifying and prioritising the essentials for safe care related to communication, leadership, person-centred care and clinical and care processes, developing the supporting information for each essential, including quick read guides, underpinning evidence bases and examples of good practice. They have been developed in such a way that they are sufficiently generic enough to be applied within any health or social care context. And we've continually sought feedback to ensure that they remain relevant to the current system issues. You can see there that there is a range of resources and an interactive website. And also within that, there is a measurement framework. The first being a readiness assessment, which enables teams to think about what state they are in for change, to understand what are the things that are going to enable them to be successful in their change, and then a prioritisation tool to think about where are the areas that they need to focus on in relation to the essentials of safe care. Alongside that runs a measurement framework, something that is very common with all of our SPSP work, to be able to understand how the improvement is actually impacting on service delivery. Next slide, please. And just to give you a sense of the level of engagement that we had through this process, you can see here the design team that was involved. So right across health, social care, the independent sector, housing, policy, our ministers as well. So we had a huge range of people that engaged in that process. Next slide, please. And what you see here is the driver diagram that acts as the interactive roadmap within the website to be able to access the resources. The 4 primary drivers reflect those priorities the design groups identified. The secondary drivers describe the key elements for each of these, and what rests behind each one is the rationale for why it's important, what is already expected, so signposting to the guided and standards, and then those range of resources and tools for people to access. These are regularly updated. So most recently, Scotland has published revised standard infection prevention control standards. So that has been the latest link. And what you will see within it is that we signpost to a range of other resources who vice versa signpost to us, so that we're ensuring that we're keeping all of this work as closely aligned as possible. We can move to the next slide, please. And as I mentioned at the start, underpinning all of this is what we call the learning system. And these are not new approaches for SPSP, but we wanted to build on the work that had already been in place over the 13 years of the programme being in existence. And it supports sharing and learning and improvement work right across Scotland and beyond. And within it, such as sessions today, to be able to hear from people, hear what's working, what's not. We also publish case studies. We have data as the beating heart of all of the work that we're undertaking, and those networks coming together to be able to share their experiences. It continues to evolve, and within that we have smaller networks that support each of the programmes, webinars, and link to a range of different online resources as well. And as we have moved through the different stages of the pandemic, that learning system has, we're delighted to say, moved to actually being back to in-person on many fronts, and most recently with our first full in-person learning system with over 200 people joining us in person, with also a streaming option online. We have a next national event at the end of September, which will bring all of the programmes together, and we'll focus on those core elements of the essentials of safe care, because that is how we will continue to create the conditions for safe care to happen for every person, with every system, every time. So I'm going to hand over to Jonathan now.
Thanks, Jo. So I'm going to cover a case study, an example of the type of work that's been taken forward in implementing the essentials of safe care, and to give you a bit of a flavour of some of the content that you will find on our learning system webpage. So this is an example of how one system used the essentials of safe care to understand their system, and it was the State Hospital for Scotland in Northern Ireland, based here in Lanarkshire, not too far from where I'm sitting at the minute. So as Jo had mentioned at the start, Healthcare Improvement Scotland had paused the SPSP programme at the beginning of lockdown, and a lot of the boards had also paused their patient safety and quality improvement activity at the height of the pandemic. The State Hospital was no different. But when we published the Essentials of Safe Care back in March 2021, it gave the State Hospital and others a bit of a push to start thinking about remobilisation and maybe some refresh of their patient safety priorities, and it gave them a framework of how they might go about that. So locally within that system, their patient safety group, their kind of governance structure, agreed that they would look at the work that they were doing against Essentials of Safe Care and begin to do some prioritisation. So taking it into the real world. So one of the first things that they did was they mapped their existing work, the work they had been doing pre-COVID, against what we had outlined, Joe has outlined within the Essentials of Safe Care. So some of those change ideas, the guidance, the examples, the evidence, they try to understand what are we currently doing and how does it fit. And it also threw up gaps and also helped them begin to start prioritising how they move out of perhaps a pandemic footing and thinking about making some of this the work is done. How did they do that? Well, they wanted to take a structured approach. So they took the change ideas that are in our Essentials Safe Care package and they scored them against 5 different criterion, giving each one a kind of 1 to 5 score based on a different kind of scale. So they looked at the scale of the change idea. How many people was this going to affect? If we implemented this change idea, was it going to affect 10% of our staff and stakeholders or 100%? They looked at the impact. They looked at the opportunity for improvement. Would this actually deliver something different? The concern around the issue itself, the change idea, what was the level of concern? And also the risk. If we didn't actually take forward this change idea, were we as an organisation at risk? So they did that internally, and as part of the process of coming up with this case study, they shared that with us. And what we did was we've taken that and made that a bit of an interactive prioritisation matrix. As you'll see, there's a little screen grab that goes alongside the Essentials of Safe Care in this case study that you can also use to begin to make sense of, could something like the Essentials of Safe Care work? And I say all of the items are scored 1 to 5, but obviously the numbers, depending on the element that they're looking at, has a different kind of name, a different kind of function. And when they're scoring a change idea, they're putting in what that primary driver is it person-centred care, is it leadership, and then they're taking maybe the secondary driver, the change idea. So what were some of the outputs from that activity when they did that and fed it back locally? Well, it's no surprise that they need to have person-centred care planning and good documentation scored highest. 25 was the top score that you could get, and it absolutely scored really high. But that package of care doesn't just look at things like safe clinical processes, it's also looking at what our previous speakers were talking about, workforce. So it's looking at things like effective rostering and making sure that you have safe staffing levels to deliver that safe care and to keep patients safe, and that scored 21. So that was a flavour of a couple of things that came out as high priorities that they wanted to take forward. Other things that we've got within the Essentials of Safe Care, things that are maybe more around infrastructure, for example, the one here about processes in place to support the application and use of evidence, that scored to 16, but that doesn't necessarily mean it was low on their agenda or any less of a priority. It's perhaps maybe they're doing really well at that, so the opportunity for improvement wasn't as high, which brought it down, but that allowed them to make sense of that internally and have that discussion. So as they move forward with Essentials of Safe Care, they're focusing their resource and they're focusing their attention. So if you wanted to learn a wee bit more about what the work the State Hospital had done and how they did it and their outputs, we have the full case study with some supporting documents available on that Learning System webpage, and we also have some other case studies and some other documents, recordings of webinars and lots of other material as well about not only Essentials of Safe Care but the broader programmes that Joe had outlined as well. And I'll pop a couple of links in the chat when I'm not sharing my screen. I can only do so many things at the one time, I'm afraid. So, questions? Hand back to you, John.
Thank you very much, Jonathan and Joe. I really appreciated that. If you could just stop the screen share, that would be really helpful so it can help people to interact now. Okay, any questions for Jonathan or Joe, please, from anybody on the call? Feel free to just unmute and go for it, you know. Well, let me help you along here. Oh, thank you, Jonathan. That's very helpful. Popping that in the chat there. Listen, we've all been under the most extraordinary pressures and so on during during COVID, and we're not out of the woods yet by the sounds of it as well. Is there any particular resource that you think is worth people trying to access if they do have a concern about safety or otherwise, to do with, it could be to do with staffing, it could be to do with prescribing, it could be to do with care received, diagnostics, transfer of care between service providers? Where do they go if they've got a concern and they work within the service? I should emphasize. Have you got any pointers in that regard, either of you, I wonder?
I appreciate there's going to be many different approaches across the UK. The first piece is within their local organisation, and to be having that dialogue within their teams, within their line management structures, to be flagging concerns through those routes, and that really would be the first and key point. There's probably no silver bullets in terms of one particular resource that you would be using. The key resource there is communication, and that first being the main focus. And when you actually look at the essentials of safe care, communication, which is probably not a surprise, is one of those 4 primary drivers, because it is central to all of the aspects of creating that open, transparent culture in which people feel safe to share or raise concerns.
Can I ask the sort of immediate follow-up questions? I think we have got some in the chat that we can have a look at as well. But let me ask the straightforward follow-up question: Are you mapping at all, or trend analysing the relative success of your patient safety Scotland protection activity? Because it's striking, you've got the buy-in of all of those organisations that you shared at the beginning. How are we doing?
So we have been using both qualitative and quantitative data as part of our process of tracking improvement for many years. We paused that during the pandemic because it does require local data collection, and we've restarted that in the last 6 to 9 months. So we're at the stages of getting that new baseline at this moment in time, but it is a central part of all of our safety programme work, and data for improvement really is the mechanism in which the local board teams are able to understand the changes they're making, and from a national perspective we're able to then see, are we making a shift for in the dial at a national level. But each of those programs are now a different stage of re-engaging in the data collection. But if you look prior to COVID, we're a program that is incredibly data rich and has some fantastic results in terms of the impact of the work.
Are you gonna, is that part of the stuff that you can put in the chat, or do people just go on your website and access it through that mechanism?
Absolutely. And so I don't know, Jonathan, if you wanted to come
Yes, John, it should be on the website. We're redeveloping the website just now, and one of the features that we're adding is describing and articulating the impact that those programs have had. One thing that the program has been able to do is actually demonstrate those improvements at kind of macro, kind of meso and micro levels. So we've been able to look at team improvements through the program and process and outcomes. We've been able to look at that by hospital site or health board region, all the way up to actually some kind of correlation with national measures around like hospital mortality rates and different things like that, more global measures. So, you know, it's never as Joe says, it's never one silver bullet, and it's not necessarily a direct line between SPSP's done this, but it's been one of many things that's taken place.
I mean, I love the richness of your approach. I love no doubt the richness of the data that you have. And you know, I write an editorial column every week for our members that goes out tomorrow. And I'm writing tomorrow, unfortunately, about the Care Quality Commission and how we're trying to inspect quality, certainly in England. And I can't understand why we're going down that route when we've got data that can really richly and easily plot out where we've got particular issues, and wouldn't we be much better off using data and spotting outliers as the places that we go and have a look at, rather than a broad brushstroke, one size fits all. Let's send the people out to inspect the living heck out of our system. Anyway, let's not go there. It's perhaps a little early in the day. Perhaps towards 4 o'clock we might consider it again.
So we could come back and talk about quality management system approaches, John. It sounds like you're straying into that territory.
Well, I fear so, yeah. But I mean, I bet you two would know. You can't improve quality by inspection. It just doesn't work as a methodology. But we seem to be politically fixated on it. But that's by the by. As you quite rightly say, let's go down that particular burrow right now. Right, Jonathan, Joe, we are very much indebted to you both. Thank you so much for sharing your insights. That was really interesting. And folks, if you're watching on the as part of the audience, there's some links that Jonathan has provided. Thank you very much indeed.